Good evening, everybody. Welcome to this evening episode of Pursue. And today we have Pursue 6E, which is liver and GI pathology. And we are streaming live from Kolkata. And today we have Dr. Bhaskar Mitra, who will be continuing with liver neoplasms. This is session 2 of liver neoplasm. In the first session, we had discussed with the benign and the nodular lesions of the liver. And today we will be dealing with the malignant lesions of the liver. Dr. Bhaskar is a very well-known consultant histopathologist of Calcutta. He has done his MBBS and MD from Kolkata, and he's a consultant histopathologist in the famous Tribedi and Roy Diagnostic Laboratory, Kolkata. He has multiple publications in international and national journals, and he's a reviewer of various journals. So before I ask him to start, let me request all of you to please keep your mic muted, your camera off, and please don't share your screen. With this, let me request Dr. Bhaskar Mitra, sir, please share your screen and start. Thank you. Yeah, I can see your screen coming. Yeah. Just a minute. Yeah, please share your screen. Yeah, please make it full screen, please.
Yes. Hope I am audible and my presentation is visible to everybody.
Yes, please.
Okay. Thank you, sir. So first of all, happy Diwali to everybody. Okay. Now I am continuing with my topic of liver neoplasms. In my last presentation, I have talked about the benign nodular lesions of the liver. Now, taking from that position, I am now continuing with this topic with the liver neoplasm part 2. Now, today I will be discussing more on the malignant neoplasms of the livers. Okay. Now, again coming back to the basics. First, what in a liver section, what we will normally see? The hepatocytes. The previous day I also started from that basic. The basic cells we are seeing: the hepatocytes, the bile duct, biliary epithelium, so many type of blood vessel in the form of portal vein, hepatic artery, different things, and the connective tissues like fibrous tissues. There may be muscle tissues. There may be other things. These are things. So this combination of the epithelial and mesenchymal elements we see in the liver sections. Now, coming to this, now today we are dealing with the liver neoplasm with a malignant. So again, the algorithm starts hepatocytic. Suppose I start with the epithelial one first. That is the hepatocytes, and hepatocytic lesions, they may look like benign. If it looks like benign, then we will follow this algorithm, so that the portal tract available, stellate scarp, FNH, hepatic adenoma, this group. No, so are we seeing the name malignant lesion? So the cells are supposed to be showing the cytological atypia or the features of malignancy in those cells. Okay. Now if we see the cytological atypia on the hepatocytic cells, first we have to consider what we are seeing. Are we seeing the hepatocytes with a mature looking morphology or looking like a immature or fetal looking morphology? If we are seeing a mature type adult looking morphology, then we are dealing with hepatocellular carcinomas. Otherwise, we are dealing with fetal like liver tissues, hepatoblastomas. And obviously the clinical findings are definitely important, whether the case is from a child or from an adult, because it's supposed to be hepatoblastoma founding in a younger age. Now coming to the carcinogenesis or the pathogenesis of these lesions. Okay, now these are the lesions what we'll see, as we know, this is at the neoplastic condition. So have to have a genetic mutation or genetic thing going on the background. So this mutation burdens, it gradually increases to transform this healthy liver cells to a hepatocellular carcinomas. So in between, we have to venture on these areas to differentiate these areas, to differentiate the precancerous and the cancerous conditions. Now, what is the background? Initially there is a hepatocytic proliferation. There are different inflammatory and the different things going on leading to the cirrhosis. And on the cirrhosis, there will be development of the regenerating nodules in the different sites. As the things progresses, there will be more and more mutations like TART promoter mutation, and every mutations are there. So there will be formation of a nodule, and this is the precancerous, the dysplastic nodules. As time goes on, more mutations, more dysplasia, more high-grade dysplastic nodules, and ultimately to the hepatocellular carcinomas. So again, looking to this picture more simplified, these are the etiopathogenic factors which causing first the proliferations of the hepatocytes, causing hyperplastic foci, regenerating nodules like this. Then there is dysplastic nodules. The dysplasia may be low grade or high grade. In those cases, those dysplastic nodules, there may be formation of small focus of hepatocellular carcinoma within the nodule. Then we termed it as nodule in nodule appearance or the early stage hepatocellular carcinoma, and then it goes on to the small hepatocellular carcinomas, that is a progressed hepatocellular carcinomas, and finally the final one. So these are the terminology we have to keep in our mind clearly. Nodules, hyperplastic nodules, followed by dysplastic nodules that may be low and high grade, then early stage hepatocellular carcinoma, progressed hepatocellular carcinoma, and full-blown hepatocellular carcinomas. Now, this is a typical cirrhosis carcinogenesis pathway. This we found in a cirrhotic background, but there may be cases where there may be de novo hepatocarcinogenesis, and that causes the direct development of these different hepatocellular carcinomas. So that can be on the lateral entities point. In that part, this pre-neoplastic condition we may not be seeing. So these are the two backgrounds, cirrhotic and non-cirrhotic backgrounds, and the series of things. These are the benign to malignants. In a non-cirrhotic background, usually these precancerous conditions are not seen. And this in the cirrhotic background, we see the whole spectrum, benign, precancerous, and the malignant one. Now, first, the dysplasia may be focal. If it is very small, less than 0.1 centimeter, we call this as a dysplastic foci. What are these? These are nothing but the expansile group of crowded small atypical hepatocytes. Now, here I will emphasize on this point, small cells. Okay, this is the important finding in a hepatocellular cases where if the cells become atypical, the cell size decreases. The decrease means the cytoplasmic volume decreases and there is an increase in the nuclear cytoplasmic ratio. That gradually the nuclear hyperchromasia pleomorphism comes, cytoplasm becomes more basophilic, and these are the small cell changes or small cell dysplasia. Now this is the picture. Here we can see this is the nodule. We can definitely appreciate and see this is not normal hepatocytes. These are small cells compared to this shape of this size and cell. Definitely we can appreciate these are the small cells with a hyperchromatic pleomorphic nuclei. The pleomorphism is definitely a bit low. Here the pleomorphic nuclear atypia a bit much more. Multinucleations of the cells more seen. So this is the small cell changes or small cell dysplasia, or this is the large cell changes or the large cell dysplasia. Here the nuclear pleomorphism hyperchromasia are much more. Their nuclear cytoplasmic ratio as usual increase. So the dysplastic definition it fulfills. That means the cells turns into the more hyperchromatic, more dysplastic cells. But remember, the size of this foci is less than 0.1 centimeter. So very small. So we call it dysplastic foci. Now, if the dysplastic foci increases, this is again the dysplastic foci with small cell changes. Look at, these are the normal hepatocytes, but definitely here the hepatocytes are smaller, but the nucleus is more prominent compared to this. So this is the small cell change or dysplastic foci. Again, this is a dysplastic foci showing large cell changes. So we have to appreciate this in this. Again, my last class, sir has importantly commented on this. We rarely get in the practicing cases this whole livers. We definitely get small trochers. In the small trochers, appreciate this minute thing is very difficult. But if you get a clear idea of what we have to see, then definitely it will help in our approach. Now, if the size increases, we call from the dysplastic foci to it a dysplastic nodule. As I am previously mentioning, dysplastic nodule is a well-defined pre-malignant lesion usually seen in a background of a cirrhosis. Non-cirrhotic livers doesn't show this type of dysplastic nodules. Again, there is a clonal hepatocytic proliferation, increase in density ratio. The nodules bulges out, or it shows a prominence from this. And one important point here, if we see the iron stain, the pulse stain which regularly do in the liver slides, here in a cirrhotic background, usually the whole liver slide is studded with the iron. But here the dysplastic nodules are less of iron, devoid of iron. So in an iron-loaded cirrhotic liver tissue, if we get a paler non-iron free area, that should raise our suspicion. We have to see the slides more carefully to determine those dysplastic nodules. Now, the name suggests, as there is a dysplasia, it should be, there is a two hand, one should be a low grade, another is a high grade. Low grade, the name suggests the minimum nuclear atypia, small cell changes are more nucleocytoplasmic ratio, but the mitotic figures are less. Large cells may be seen, and most commonly a few scattered large cells can be seen, but low-grade dysplastic nodules usually show the small cell changes. As it is high-grade dysplastic nodule, the small cell changes are more prominent. Architectural atypia is there, but again those cutoff points, the 3-cell thickness of the trabeculae is maintained. It doesn't go more than 3 cells, because if it goes, then we are probably dealing with a high-grade dysplastic nodule. Now, if we see in a focus, suppose this is, we found a dysplastic nodule. Now, in a focus, we got this proliferation of these hepatocytes, which making the cells more bit malignant. So, we find a separate nodule within a dysplastic nodule. So, we call it nodule in nodule appearance. Now, here I would like to share one important thing. How the morphologically the liver cells progress to malignancy. The malignancy suggests, what is the definition of malignancy? Surest sign, invasion and metastasis. So here the metastasis is different. Now here we are dealing with the invasion part. Now how the liver cells proliferate and grows? It's a lobule here. Okay. Now there the cells are dysplastic. Now as the cell progresses from a small foci or nodule to a bigger hepatocellular carcinoma, it goes into the stromal invasion. As it progresses and it invades the stoma. Here we found two important morphological things. The neoplastic cells gradually progresses to the normal parenchyma and it invades the or infiltrate the adjacent lobules, or it engulfs the portal tracts. Initially through sinusoids they get the blood vessels. As it progresses, there is capillarization of the sinusoids. So when normally in the sinusoid we don't see the endothelial linings. As it progresses to the malignancy, the capillary proliferation increases. So here we can see more and more endothelial lining cells. and that is well appreciated if we see a CD34 staining in the liver cells. Here the CD34 will show the endothelial lining. In the FNAC, again the hepatic course with a cuffing or a layer of endothelial cells sometimes can be seen in cases of malignancy. So this point has to be remembered always, that is the sinusoidal capillarization. As it progresses, it increases. Again, this is a low grade nodule. High grade nodule, this one with the small cell changes. Here you see the architecture has been a distorted one. Again, this is a nodule formation. Okay, so now we have moved from a regenerating nodule to a dysplastic nodule with low and high grade dysplasia. We understand what is small cell changes and what is large cell changes. Now, as what I said earlier, the stromal invasion. Here we can see the malignant, these small cells are doing the stromal invasion. Here we can see entrapped portal tracts, entrapped capillaries or blood vessels, that is the portal tract blood vessels, in between which these hepatocytes, the tumorous hepatocytes are going through. So there is stromal invasion. We have to look for this. This is very important one. As it progresses, it will destroy the whole thing. Now from the dysplastic nodule, we gone to a step ahead. Now we are in a small hepatocellular carcinoma. The cutoff less than 2 centimeter diameter. That's important. Okay. Now there are two things: early hepatocellular carcinoma and progressed hepatocellular carcinoma, or small progressed hepatocellular, as the size is small. So early to progressed. So once it's early, it has got an indistinct margin. As it goes progressed, it will have a distinct margin. Okay. Earlier you cannot, but just remember like this: if it's an early lesion, you have hesitated to call it malignant or non-malignant or dysplastic. So the margins will be indistinct. You cannot separate it out. Once it progressed, we can separate out. We say it distinct. Now, so the progressive hepatocellular carcinoma is again morphologically can be said distinct nodular hepatocellular carcinomas, and the early one can say vaguely nodular hepatocellular carcinomas. Now, the distinct one, as it's distinct, so it's a bit more differentiated, that is moderately differentiated, and definitely it will lose the portal tract because the tumor cells has gone there and there is a microvascular invasion may be there, capillarization will be more because it's almost gone progressed, so it's more hepatocellular carcinoma. But in the vaguely nodular type, you may rarely get the portal tract. Cells are started to do this stromal invasion part because it's already hepatocellular carcinoma. It has progressed from the dysplastic nodule, and definitely the distinct nodules are surrounded by a fibrous tissue. That's why they are distinct and the margin is distinct. That's it. And they moderately different a small hepatocellular carcinoma because the focus of the hepatocellular carcinoma is small, less than 2 centimeter. And this one is the early one. They are vaguely cellular. The cellular, we can see the difference of the cellular pattern here, but definitely that distinct margin is absent here. So it is the early one. Here we can see the portal tracts in between which the cells are unique. The stromal invasion part is very prominent here. Okay, so now we moved from dysplastic to an early one by small hepatocellular carcinoma. Okay, so this is the distinction: large degenerating nodule, cirrhotic background, low grade, high grade dysplasia to early hepatocellular carcinoma. As the thing progresses, the small cell changes increases more and more in the early thing. Large cells can be seen in everything. Mitosis gradually increases. The 3 cell layer thickness is up to dysplastic nodule is less than 3. As it progresses to early hepatocellular carcinoma, the reticulin framework is disrupted and that is more than 3 cell layer. So extensive reticulin framework loss will be in the hepatocellular carcinoma. So in a liver biopsy slide, we have to see the reticulin very carefully to see the reticular framework. Now, as seen, the early one has got an indistinct border. As it progressed a step ahead, it becomes distinct. Stromal invasion definitely positive because it's a carcinoma. Here is dysplastic nodules, normal invasion is less. Here is more concentrated on the cellular changes. I think everything is clear. Now, it is a full-blown hepatocellular carcinoma. This is the background. Commonly in a chronic liver disease, BC infection, adult patient, middle-aged. Now, the patterns, what we are see in the hepatocellular carcinomas. Here we can see the hepatocellular network. The reticular network has been disrupted, smashed. So cell thickness is very big. The normal lobular architectural pattern is gone. What I mentioned, the CD34 positivity in the capillaries, which is not seen here, widened. And important thing is we can see the bile, presence of bile. That is very important because in a non-immunohistochemistry cases, this is an important sign of hepatocellular differentiation. If we see the bile, we can say this might be a case, this is definitely a case of hepatocellular carcinoma because other cells do not produce the bile, only hepatic cells. Now, what type of growth we usually see? It can be expansive, it is the expansive nodular growth, or it can be a infiltrated growth, mixed one, expansive infiltrative mixed, diffuse, or maybe pedunculated, pedunculated lesions. So these are the things. Now, pictures. Expansive growth, expansive nodules within the parenchyma, liver parenchyma, or maybe a bit bulging outside, more appreciated in the reticulin state. Here we can see the expansive growth. It may be infiltrative, ill-defined borders, growth, ill-defined borders infiltrating here and there like this. This is an infiltrative growth. This we see in the gross examination, what type of growth it is. This is very important. And this is a diffuse growth. In other words, we see a bit of nodularity here and there, here and there. Someone says this is a diffuse type of hepatocellular carcinoma or serotomimetic. It looks like the liver one. So serotomimetic one. Now, microscopy. What we see in the microscopy, what are the patterns? This thing will help for the postgraduates to write the description. First, trabecular pattern, pseudoglandular or acinar pattern, or compact solid patterns. What are those patterns? Sorry, this one, trabecular patterns. Track of cells. The tumor cells grow in cords with variable thickness, separated by prominent sinusoids lined by flattened endothelium, because already capillarization is there. Capillarization here occurs, and these are the trabeculae, the tracts of cells, the trabeculae of cells, the typical characteristic of trabecular pattern. Now, this is a pseudoglandular pattern. Here, see the ill-formed glands here and there, everywhere, acinar formation, variety of gland-like structure. This is a pseudoglandular pattern. Again, the reticulin framework network lost, pseudoglandular with presence of bile. So again, a specific marker for the hepatocellular differentiation. Now, this is the solid pattern. No glands, no trabeculae, a solid pattern of cells. This appears to be a solid mass. It shows a compression to the adjacent parenchyma, and here is the solid pattern of growth. Now, as per WHO, the hepatocellular carcinomas are graded into well, moderate, and poorly differentiated. As the well moderate is the early stage less than 2, it shows on the nuclear atypia. Mild nuclear atypia, increased nuclear cytoplasmic ratio, this different type of patterns, we call it well differentiated. A bit more, mainly trabecular growth pattern, abundant eosinophilic cytoplasm, round nuclei, atypia a bit more, we call it moderately differentiated. Poorly, what we see, definitely we can understand this is a hepatic origin. So that will be poorly differentiated. Poorly differentiated, we can't recognize. Well, we have difficulty with the normal liver. So this, and in between is one, is the moderately differentiated. Poorly one, as shows the marked pleomorphism, sometimes maybe small c. Edmondson, there is a grading of Edmondson that divided into the 4th part, again based onto the nuclear atypia. Larger nucleus, from this one look like a normal liver, simulate, best differentiated, grade 1. Grade 2, the larger nucleus. Grade 3, nuclear chromatia more increases, less cytoplasm, and marked pleomorphism, hyperchromatia, scanty cytoplasm. and there is a loss of trabecular pattern. This is one is grade 1. The nuclear atypia increases, the trabecular pattern almost going to a sheet-like appearance, trabecular pattern a bit lost. Here again the nuclear atypia much greater than from this grade 2-1, the nuclear irregularity, hyperchromasia, pleomorphism a bit more, and this is in a extreme variant. There is a multinucleation, pleomorphic nuclei, prominent nucleoli. So this grade 1, 2, 3 and 4. Okay, so as the progresses, the nuclear grading of the hepatocellular carcinoma like this, or we can do well, moderate and poorly. So from the, so there will be things, hepatocellular adenoma, the benign one, to do the missing link, well differentiated hepatocellular carcinoma, the in between one, at the final hepatocellular carcinoma, and in between this there is a high grade dysplasia. As the thing progresses, there will be different changes. Now coming back again to the morphology part. So what are my key points? First, paucity of the reticulin network, cell plates more than 3 cells thickness, presence of abundant acina, pseudoglandular or trabecular pattern, the cells showing atypia. These things are my key points. So when even in the TrueCut biopsy, if we don't see the typical morphological lobular network, we have to raise the suspicion. Look at the reticulin stain, more than 3 cell thickness, raise the suspicion. Look at the cytological atypia. If it is more poorly differentiated, look for the bile. If it is present, it will be helpful to diagnose it as a hepatocellular carcinoma. And the vascular pattern is there, the sinusoidal capillarization. This one is poorly differentiated. What I am saying, in the previous one, we can see, appreciate the liver origin. Just compare this picture. A bit hepatic origin, we can say hepatoid looking cells. Here we definitely can't say it's a hepatoid looking cell, it can be anything. Okay, so this is a poorly differentiated hepatocellular carcinoma. This is showing a bit trabecular arrangement, solid seeds, a bit trabecular, pleomorphic cells. Here is a pseudoglandular type appearance. These are the poorly differentiated hepatocellular carcinoma. If you find the bile, very good. Otherwise, we have to take the help of the immunohistochemistry stains. Now, these are the different patterns. The glandular architecture, hepatocellular carcinoma, eosinophilic cytoplasm, the more pleomorphic glands, presence of bile, sometimes they are dark green bile somewhere. Sometimes it shows eosinophilic, a bit of steatotic changes in those cases. Intracytoplasmic globules may be there. These are the eosinophilic granular cytoplasm. Usually what we see in cases of hepatitis B virus infection, chronic liver disease with hepatitis B. This is again HBS staining, hepatitis B antigen staining showing this type of HBsAg positivity on those cells. So these are the things what we can see in a hepatocellular carcinomas. Now there are different morphological variants. Like it may be steatohepatic type, showing a histologically steatohepatitis like appearance. It may be clear cell type, where more than 80% of the tumor cells showing. Now, up to this, we are dealing with a hepatoblastoma cases. Hepatocellular carcinoma, the adult looking one. Now, if the cells look a bit fetal or immature type, and the patient is a younger one, then we have to look for hepatoblastoma cases. Okay, they are usually well circumscribed lesions. It may be of varied morphology. It can be epithelial, showing fetal type with polygonal cells, embryonal and fetal type, macrotabicular type, small undifferentiated type. There will be mixture of epithelial and mesenchymal combination here. This is the first, the fetal type. Here the cells are small, uniform looking. It doesn't look like a mature hepatocytes. A clear cell changes over there, oval round to oval nuclei, finely granular cytoplasm. Sometimes they may show the macrotrabecular type of arrangement, a more pleomorphism. Here the combination of clear cells, a bit of small cell area arrangement here and there. So this we see, this type of things, definitely we can say this is a malignant lesion. In the background of this, immature looking cells, think of hepatoblastoma. Sometimes If this picture shows, it definitely looks a blastomal appearance. That is embryonal type. This shows the cells arranged in small cells, arranged in cords, rosettes, ribbons-like appearance as seen in the other blastoma cases. There may be small cell undifferentiated type. The cells are small, undifferentiated, hyperchromatic nuclei. Prominent vascular network is there. More pleomorphism, more aggressive nature, more mitosis is there. These are the different patterns of hepatoblastoma, what we can see if it is pure epithelial. Now, if it is mesenchymal, life would be a bit easier. Here, we can see as a mesenchymal component like a connective tissue or fibrous tissue proliferation, immature mesenchyme-like appearance. There may be osteoid formation. Even we can see calcification and the cartilaginous differentiation also. Here we can see this is a mixed epithelial and mesenchymal types. So this is the morphology of a hepatoblastomas. Now in the hepatoblastomas, one is the important thing I like to mention regarding its prognosis. There is a pre-tumor extension is one important thing that WHO mentions. It says how much the tumor involves and what are the extra annotation factors that helps to make the prognosis of this hepatoblastoma cases. Whether one section is involved and the 3 adjoining sections are free, 1 or 2 sections are involved, 2 adjoining sections are free, 2 to 3 sections involved but no 2 sections are free, a bit confusing. This picture will have. Okay, this is the liver, different segments we divide with the presence of portal vein, IVC and different things. If it is pretext 1 involved, other consecutive 3 free. Consecutive 3 free, 1 involved. 1. 2 consecutive 2 free. Consecutive 2 free, this 2 involved, this 2 free. This 2 involved, this 2 free. This one involved, this 2 free. Or this one involved, here 2 is free, 1 is free. So this is again 2 not involved, 1 free. This is stage 2, 3, 1 is free. Here this one involved, this one is free. You can see, and the stage 4, all the consecutive ones are involved in a continuous fashion or in a multifocal fashion. So this picture will be easier to understand in this one. This is the write-up I copied from the WHO. I found it very difficult to remember, but this picture will help. Okay. Now other things, whether the hepatic vein or inferior vena cava is involved, portal venous involvement, extrahepatic spread away from the liver, multifocal tumors, tumor ruptures, tumor involving the caudate lobes, lymph node metastasis. On this ground, we differentiated into this 1 and 2, pre-treatment extent of the tumor, good prognosis, 4 more, age less than 1 year, more than 6 years, alpha protein level low or high, very high, histological type, pure fetal type of hepatoblastoma with low mitotic activity, well differentiated type is got a better prognosis. Small cell undifferentiated, more blastomal like, it has definitely got a bad prognosis. On this ground, the extent of the tumor, morphology and other associated findings help to determine the prognosis of this. So now we have completed this, the hepatocytic part. Now we are shifting to this biliary part, biliary epithelium part. Now again, the biliary part, biliary epithelium, premalignant lesions. Dysplastic nodule, hepatocellular carcinoma, here is the premalignant. What are these premalignant lesions? As we are dealing with the biliary neoplasm, so it has to be biliary intraepithelial neoplasia. There are 2 entities, 2 intraepithelial neoplastic entities. One is the biliary intraepithelial neoplasia, another is the intraductal papillary neoplasm. The name suggests, just imagine small biliary type epithelium tubules, biline and intraductal large ducts with a papillary architecture, IPNB, intraductal papillary neoplastic lesions. So these are the 2 premalignant conditions. Coming to the biline, these are microscopically flat or low papillary appearance dysplastic nodule. previously said it was a biliary dysplasia. Bilin can be divided initially into bilin 1, 2, 3. Now, conventionally, bilin 1 and 2 has been grouped into a low-grade bilin and the group bilin 3 into the high-grade bilin. Now, coming to this. Biliary intraepithelial neoplasia, as the name suggests, this is a flat type of dysplasia. This is a group of tubular-like structure. Here we can see the dysplastic changes compared to this normal one. But no stromal invasion, a small bit of papillary projections here, flat type of dysplasia. There may be multiniary, micropapillary architecture. Here we can see a bit of micropapillary architecture here and there, detached papillary fragments. These are the biliary intraepithelial neoplasia, bilin group. Now, how to differentiate the bilin 1, 2, and 3? I am coming back to this, just compare with intraductal papillary. Here we can see the prominent papillary biliary architecture. Here we can see it's a more like a large tubule and the large ducts filled with a papillary projection, papillary growths with the dysplastic cells lining here and there. That may be low, intermediate, and high grade. So here, comparing to this and this picture, here this is a flat type, small papillary projection. This is a more of a papillary type with a large duct, as a tubulocystic appearance. Now, classify how to bilin 1, 2, 3. Bilin 1 is a flat micropapillary architecture, focal crowding, pseudostratification. Here we can see the nuclear polarity is maintained. That is basally located uniform looking nuclear. As the thing progresses, higher nuclear cytoplasmic ratio, because it is intraepithelial neoplasia, the nucleus has to be dysplastic. Now, bilin 2, it's loss of cellular polarity, more hyperchromasia, more changes in the cellular atypia, and bilin 3, pseudopapillary or micropapillary architecture, almost looks like carcinoma without any invasion. So, this is less, a small bit of nuclear atypia. This looks like in situ carcinomas. In between is the bilin 2. Now, this two grouped under low grade, this one grouped under high grade bilin. Okay. Now, coming to the intraductal papillary biliary neoplasm. Intraductal papillary biliary neoplasm. Previously, it was said biliary papillomas or papillomatosis. You can understand why it is called so. The nuclear atypia is low, intermediate to high grade. This lining epithelium are lined by the biliary cells. They may show intestinal type of metaplasia, oncocytic changes, or even gastric type of metaplasia also. They show expanded alveolus growth-like architecture. It may progress to invasive carcinoma, okay, and it may lead to the tubular carcinoma. As the intestinal and the gastric type is there, mucinous changes can be commonly seen in these cases, which is usually not seen in the bilin cases. This is again more of a papillary architecture, more dysplastic, but no invasion. Again, IPNB, that is intraductal papillary neoplasm. Now, if from the pre-malignant to malignant, what we are dealing with? Cholangiocarcinoma. Today we are dealing with, this may be intra and extrahepatic. We are today dealing with morely intrahepatic, that is ICCA, that is intrahepatic cholangiocarcinomas. Intrahepatic tumors are usually well circumscribed, form nature. There may be extrahepatic lesions. This well microscopically they shows glandular and tubular architecture here and there, with a prominent fibroconnective tissue meshwork in between this, and it shows a definite desmoplastic reactions. The lining epithelium shows a definite pleomorphic nuclear papillary architectural pattern, and they may invade into the surrounding tissue, and sometimes in the poorly differentiated cases, this tubular architecture is lost. I will show you the pictures. They may or may be a nest and ducts, tons of cells everywhere. Now, in the recent WHO, the intrahepatic cholangiocarcinoma has been divided into the two things. One is the large duct intrahepatic cholangiocarcinoma, another is the small duct. They said that what I said earlier, that is the bilin and the intraductal papillary neoplasm will give rise to this large duct things. And regarding the small duct things, the difference from its pathogenesis, from where it has been arised, a bit questionable. Some says these are the transform or transdifferentiated liver progenitor cells or mature hepatocytes give rise to this cholangiocarcinoma. So this is the biliary epithelium giving rise to cholangiocarcinoma. Sometimes there may be hepatic origin that may give rise to cholangiocarcinomas. So there are large duct cholangiocarcinomas, there may be small duct cholangiocarcinoma. Some says biliary adenofibromas may give rise to this small duct. So this one pathogenesis is a bit doubtful, but this one, this two. Okay, now coming to this. What is small duct type and what is large duct type? Now look at the etymology or the science of nomenclature. Small duct type, we see small ducts, and the large duct type, it's a large ducts. So it is more of a small ducts are on the hepatic parenchymal sites. It's mainly on the hepatic parenchymal sites, and they show a mass forming pattern. Mass forming patterns means they form a mass. But the large duct one, they may show a periductal infiltrating pattern, like a duct opening, duct lining epithelium showing carcinomas, and that are infiltrating everywhere. So that may be mass forming, but this type of periductal infiltrating pattern is more common in the large duct areas. Now just see the morphology. This is the large duct one. Here we can see the large ducts, the papillary neoplasms, as said, that is arising from the IPNB, and they showing a typical stromal invasion. Sometimes this one is lost, and the more and more cells infiltrating the stroma. These are again this large ducts infiltrating into the stroma. Okay, here we can see prominent large duct, lined by neoplastic cells showing proper perineural invasion here. The cells are invading, and in between this there is a desmoplastic stroma. There may be so poorly differentiated, we can see only nest of cells in a dysplastic stroma. So these are the large duct pattern, and this is the small duct pattern. Then we can see small ducts. Okay, again see this honeycombing appearance, small ducts. Here these are the small ducts showing the tubular pattern, and sometimes again there may be desmoplastic stromal component in between the tumor cells and the tumorous glands. This may be so poorly differentiated, shows polygonal nest of cells, even with a squamoid appearance. They show in a connective tissue stroma, again showing desmoplastic reaction. So this is small duct type of intrahepatic cholangiocarcinoma. So these are the two different type of cholangiocarcinoma. One is large duct type, another is a small duct type. Now there are the different characteristic things. Adenocarcinoma component is there. Okay, and the large duct one may show mucin secreting glands, but the small duct one do not show any mucin secreting glands. So these markers are more helpful in the mucin secret, because IPNB is one of the things that may show mucinous metaplasia, gastric intestinal type. So large duct come from this, so it may show mucin secreting areas. Okay, but this one is not seen here. Okay, small duct type. Now immunohistochemistry. These are typical biliary type of things. So they show the CK7, CK19, CA19.9 and monoclonal CA positivity. And other these markers, HEPAR1 may be focally positive, but usually negative, negating this hepatocellular origins, typically showing the CK7 appearance. So this is about the cholangiomes. Now in the epithelium there is a overlap. One, what we see, the hepatocytic one, and the cholangio, the biliary one. But what I see in the small one, there may be transdifferentiated hepatocellular ones, hepatic cells that may give rise to cholangiocarcinoma. So there is one entity called epithelial malignancy with a mixed cellular origin. What is the definition of this? This shows a combined hepatocellular and cholangiocarcinoma-like appearance. There is a merging of the histological and both immunohistochemical pattern on the same group of tumor cells. No, sorry, different group of tumor cells, but both the things are present in the same tumor. Okay? Same mass showing both tumor types. So hepatocellular carcinoma component, all of this possible cytoarchitecture. Here we can see the trabecular appearance as seen in the hepatocellular carcinoma. We make sure this typical macrotrabecular, the glandular appearance with a desmoplastic stroma seen in the cholangiocarcinoma appearance. So component of both malignant adenocarcinoma component along with this hepatocellular carcinoma component can be seen in a same tumor mass. Here we can see this is a classical picture of a hepatocellular carcinoma, gross showing hepatocellular appearance, macrotrabecular one appearance, neutrophil network notch. This is a cholangiocarcinoma, shows the dysplastic glands lying in the liver parenchyma with a prominent desmoplastic stroma. This is a classical hepatocellular carcinoma appearance. This is a cholangiocarcinoma appearance. Now look at this tumor. Half part showing this hepatocellular arrangement and half part showing this cholangiocarcinoma-like appearance. So there is a mixed epithelial pattern. So two type of tumor merging together, and this one more confusing, that is an intermediate. So there is a monomorphic population of tumor cells. Phenotypically, they neither show the classic HCC nor the classic intrahepatic cholangiocarcinoma type. So these tumor cells are small tumor cells arranged in trabeculae, cords, solid nest, small solid nest in a background of a desmoplastic stroma. As they show a mixed phenotype, they may show both hepatic. This one is arginase and alpha fetoprotein staining, which are usually positive in cases of the hepatocellular carcinomas. They are positive here. Even CA19.9 or CK19 can be positive here in these cases. So they shows both markers of hepatocytic and cholangio. So that can be mixed, that can be intermingled. So hepatocellular carcinoma epithelial, cholangiocarcinoma is intrahepatic, and there is a mixed epithelial malignancy and the intermediate cell carcinoma. So this part completes the epithelial group. Now going to the tumors of mesenchymal origin. As the picture I have shown earlier, the mesenchyma, we see the blood vessels. So the malignant tumors of vascular origin, the classical one is the angiosarcoma. Okay, here we can see this intercommunicating connecting vascular network with the malignant looking, angry looking cells with the dysplastic changes with a sinusoidal pattern here. This is a case of angiosarcoma, which is commonly occurs in the liver. This one is the epithelioid hemangioendothelioma. This is a relatively rare vascular neoplasm, but characteristically it shows small nest of cells with scanty cytoplasm, and there may be small lumens here representing this capillary lumens. There may be hyalinization of the stroma area. The small cells may be a vacuolated appearance, cytoplasmic vacuoles, some contains the RBCs, suggesting of its vascular origin. There may be spindle to stellate shaped genetic cell type appearance in the myxoid stroma. This is a intermediate grade malignant tumor of the we usually find in the liver. These are the epithelioid hemangioendotheliomas. Now coming to the more connective tissues one, we can find the rhabdomyosarcomas in the child again. There is a spindle to stellate shaped cells, sometimes strap cells like are present here. They shows more pleomorphic cells with eccentrically pressed nuclei, hyperchromatic nuclei, prominent mitotic figures. The characteristic immunohistochemistry markers are positive in the embryonal rhabdomyosarcoma cases. We can have a fibrosarcoma, connective fibrous tissue derived malignant cells in the liver. Here, there we can see the hypercellular spindle cells within intervening herringbone pattern appearance like this, interconnecting fascicles with a cellular morphology showing malignancy, high-grade spindle cell lesions. Sometimes the mitosis are there, are relatively low maybe, but these are the fibrosarcomas, the conventional ones. These are the leiomyosarcomas from the smooth muscles. Again, this pleomorphic cells, giant cells may be there. This is the interlacing fascicles of cells, the conventional leiomyosarcoma like malignant spindle cell appearance, which can usually occurs in the cases of liver. Now, there may be embryonal sarcomas or the malignant mesenchymal undifferentiated sarcomas. They usually seen in the children, as the name suggests, the embryonal groups. They shows high leukocytosis and increased alkaline phosphatase level. The cells are stellate shaped, may show glandular or a bit of sometimes cystic appearance. The cells are markedly anaplastic. You can see prominent mitotic figures, high-grade mitosis. There may be spindle cells may show, as its mesenchymal origin, may show osteogenic or cartilaginous differentiation. This also shows some amount of extramedullary hematopoiesis also. So it is another group, embryonal sarcoma or malignant mesenchymal tumors. And there may be other tumors like this chart is a bit smaller appearing, but if you see the documents, then you can appreciate. I just highlighting these things. I clearly mentioned the embryonal rhabdo, embryonal sarcomas, fibrosarcomas, leiomyosarcomas. Here we want to mention the two things. One is the liver may shows the neuroendocrine tumors, the classical carcinoid tumors and the neuroendocrine carcinomas. There may be mixed epithelial neuroendocrine carcinomas, maybe they are manic like this, and sometimes there may be germ cell tumors like erector sac tumor may be rarely seen in the liver. These are malignant ones. And last but not the least, the metastatic tumors. Everywhere, lots of body parts, the metastatic tumors may come into here. Most characteristic radiological finding, the multifocal appearance. It may be single focus, but the multifocality is important. It may be from the bile duct, most commonly seen, bladder, breast, cervix, colon, throughout the GI tract, draining through the portal veins, coming to here, gallbladder, kidney, lung. These are the important areas. Others are the ovary, pancreas, almost all organ from every part of the body can shed their metastatic nodules into the liver, giving rise to this metastatic tumors. These are the different metastatic tumors. This one I especially like to mention. This is a melanoma case. Metastatic melanomas in the liver is very common. We can see this brownish pigment here and there in those cases. Okay, this is very important because we have to differentiate from the other epithelial tumors. Only differentiate one. This is showing the metastatic adenocarcinoma component and the panel of immunohistochemistry markers. We take the help of metastatic profile. We do CK7, CK20, and then we do the organ specific screening. The CK7, CK20 helps us to channelize our markers. If it is CK7 positive, 20 positive, CK7 positive, 20 negative, 7 negative, 20 positive, these varied combinations we use and we do other supporting markers. Sometimes we may pinpoint it with the help of definitive marker, but sometimes we have to take the differentials of the DD, because one thing we must remember, the key factor is if tumor is there in a specific organ, the metastatic usually belongs to that. Okay, before calling it a different tumor, think twice. This may be rare presentation or rare expression of some of the markers, or maybe absence of some of the classical markers, but still if a tumor from definite organ we can find in radiologically, clinically, and by other investigation like endoscopy and everything, then the metastasis usually belong to that tumor. okay, before going to venture to the newer tumors. So again, the summarize this malignant lesions. Again, I will take the help of an algorithm. There is a malignant mass. So epithelial or mesenchymal. Mesenchymal ones relatively easier. Go to those connective tissue tumors or soft tissue tumors like vascular, fibrous, and muscular, etc. If epithelial, is it hepatocytic or it's a biliary type? Look at the, if it is hepatocytic, whether that looks like adult cells. If it is adult cells, we are dealing with probably hepatocellular carcinomas. And definitely here malignant mass, we considering that it's a single large mass, not a metastatic one, which may be multifocal. If it is biliary, is it small duct, multiple small honeycomb-like appearance ducts, small duct carcinomas, or it may be large duct. We look for the bilin and interductal papillary neoplasms, precancerous conditions, that will helpful. Radiology is helpful. Again, the immunohistochemistry markers, typical characteristic papillary architecture is there. Here the small duct architecture is there. And then the confusing parts, the two mixture ones, epithelial malignancy with mixed cell origin, both of this hepatocytic and biliary simultaneously present in the same tumor mass, and another is the intermediate one showing both type of excretion in the same tumor cells. This one, these two are intermediate between these two groups. Otherwise, if we follow this algorithm, but again I am saying it is not that simple. In the true cut, it will be sometimes very difficult to differentiate, but most of the cases with a conscious and a meticulous examination of the morphology, immunohistochemistry, ancillary markers will help us to differentiate these tumors. So again, this completion of my talk, and happy Diwali to everybody, and some happy Diwali wishes to all those who are listening to this presentation of mine.
Thank you. Thank you, Dr. Bhaskar. A lot of people are listening and there are a lot of questions and queries also. Wonderful presentation at the outset. Very nicely done, very well explained, and especially the difficult areas have been sorted out with all the good algorithms which you use. Very nice for the students, consultants, as well as residents. Can you just stop presenting so that people can see you? There are a lot of questions. Will you be taking this question right now?
Yes, or yes, just some of the questions I can definitely take.
Just stop presenting so that people can see you on the YouTube. Questions are mostly from the YouTube. Right. I think your camera is not on.
Yes, sir.
Great. Yeah. Now, please just remember that there is a small time delay between your answers and the thing appearing on the YouTube. So I will go one by one. First, there are 2-3 questions from Dr. Minesh Gandhi. First question is how to differentiate steatohepatic HCC from steatohepatic changes in FNH in the biopsy.
That is definitely a difficult one because the FNH, first of all, we have to take consideration of the overall context of the thing. Okay, FNH is a neoplastic tumor-like appearance. The atypia, cellular atypia and other thing is less here. But in the steatohepatic type, this cellular atypia and the morphological differences are more on the malignant side as is there, and there is definitely in the hepatocellular carcinomas there may be fatty changes at places that sometimes may be confusing, and the FNH has got in the gross appearance the characteristic skeletal scar appearance which may also help in some cases, but definitely we look for the cellular atypia, the malignant changes in the cells, and again one thing, the reticulin network. The reticulin network in the FNH, we don't see those expansion on destruction, but in the hepatocellular carcinoma, definitely that will be destructive.
Not the fibrous, in the fibrous band you might see some ductular proliferation in FNH, which is not seen in.
Definitely.
And you may also see in some thick wall blood vessels, these are all really fine markers, thick wall blood vessels are present in FNH, which is not present in HCC. These are very subtle areas, and of course you need to look at it very carefully. There is another question by Dr. Minesh Gandhi. Is fibrolamellar HCC morphological diagnosis or CK7 CD68 must before sign out?
No, it's more of a morphological diagnosis that will help add on to this. But fibrolamellar is definitely more of a morphological diagnosis. Sometimes if we see lots of fibrosis and everything, if we can do the immunohistochemistry part, definitely that will corroborate, or definitely we can say these are things. And again, the context, the other things, the alpha fetoprotein levels and the background, the cirrhosis and other things, we have to take into the consideration.
Yeah, that's right. Alpha fetoprotein level is very important. Yeah,
very important in the fibrolamellar.
Very dicey, there.
Sometimes it may be dicey because sometimes we have. Sometimes we
many times it is very normal.
Sometimes we can see the raised also in the fibrolamellar type. Right. That will also sometimes bit confusing. These are the soft points.
There is another question by Dr. Minesh Gandhi. How to differentiate HCC from epithelial hepatoblastoma in biopsy in older children?
I think we have to take the first of all that typical the epithelial type one is at first of all the context and the morphology, and we also have to take, because the immunohistochemistry not much of help here, because both the hepatocellular markers will be there. And again, those things, that is the morphologically, if we see some small cell like appearance, a bit of immature cells, that will also help to differentiate on this hepatocellular carcinomas from this fetal type or epithelial type of hepatoblastoma.
Right. So, there is a question for Dr. Munaza, who says how to differentiate intrahepatic cholangiocarcinoma from metastatic adenocarcinoma. Very common.
That's the immunohistochemistry definitely short out this thing, and this typical the metastatic from the liver and gallbladder and this thing. Sometimes we cannot see because it's the same biliary type of epithelium is there, and again if the mass is radiology here is helpful. If we see a mass in the gallbladder or the extrahepatic tissues, that may be, and see multiple foci of lesions in the liver, that will be more of a metastatic. And if we don't find any other lesions in the near vicinity and the lesion in the liver showing a biliary type of immunophenotype, then it is more life of interpretation. And one thing is important, we have to look for the precancerous, that is the bilirubin ones, the precancerous lesion. If we see the adjacent vicinity, those precancerous lesions, that definitely helps to get that differential line.
True. Actually, we have to take the whole thing in the total context. The history, the radiology. Especially the ultrasound and MRI reports.
Ultrasound and MRI.
Based on that, especially in small biopsies, it becomes very difficult to just one shot answer.
No, that is definite. And the biliary epithelium is definitely. Other things can be sorted out because the lung metastasis from the biliary, that can be sorted out. But from the biliary and that context, the whole thing is important here, sir.
That's right. Yeah. Just let us wait for 5 minutes, for 5 to 10 seconds before the answer goes to the YouTube, so that if there is any counter comment, then we can just wait for that.
Definitely.
Otherwise, most of the things have been sorted out. Wonderful presentation, Bhaskar. Very nicely done. Excellent.
I tried to make the things. Life is not easy for those liver true cuts and small biopsies. But I tried to make these things a bit simpler so that we get the basics right first, so that we can proceed on those basics.
Yeah.
So that's the thing.
Many a times most of the teaching is done on autopsy specimens.
Definitely.
And most of the reporting is done on true cut specimens.
True cuts.
That is the irony of the whole thing.
Oh, yes, yes.
And reporting on TrueCut at times, and especially the material is so less, and you
Ah.
don't have access to all the immunomarkers at times. So it's
Sometimes
tough.
one of my seniors, sir, he was a surgeon. He said, I said, it's a small biopsy, sir. Up to that much I can comment on this biopsy. Then he commented on reply, what you are asking for, should I cut the whole liver and give it to you for your diagnosis?
Yeah,
Then what
that's
is
right. That's,
it? But it's really difficult, nightmare for every pathologist.
yeah, that's true. So there are no questions. Thank you, Dr. Bhaskar. Excellent. Happy Diwali to you and your family. Thank you
Thank you,
very much
sir.
for this wonderful presentation. Please
Thank
share
you.
the PDF so that we can share it with everybody. Okay.
Definitely.
Bye-bye. Good night. Take care. Bye. God bless you. Bye.
Thank you. Thank you.